welcome everyone to another episode of Breast Cancer Conversations. I am excited to continue this conversation that we've been exploring over the last couple of weeks around living with a metastatic breast cancer diagnosis, and then also understanding the various diagnostic and treatment options that are available to us.
So let's dive right in and meet our panelist.
My name is Dr. Groteluschen. I'm a medical oncologist here in Green Bay at Green Bay Oncology. A little bit of my background, I'm calling in from Green Bay. A little bit of my background, though. I grew up in Iowa. I went to medical school at the University of Iowa, and then I did my residency and fellowship at the University of Wisconsin in Madison. And then basically, once I got done with residency and fellowship in oncology, I came to Green Bay Oncology, and I've been here for 16 years practicing medicine. We are a comprehensive, we're a large community group here in the Green Bay that serves both basically Northeast Wisconsin and the Upper Peninsula. We also are a member of it's called an NCORP, but we're one of like 40 or 50 institutions that do clinical trials, not in the academic centers, but in the community residency or community locations. And Tammy can potentially support what I'm saying here, but we really view ourselves as a tertiary hospital in Northeast Wisconsin. We get a lot of people that come from the area regionally, and then we have a lot of connections with our regional academic sites in the area too. So we're probably about 11 to 12 physicians. We do medical and radiation oncology. We have multiple APPs, and we serve a large area, and all, I think, very well-trained physicians. And when I was in Madison, I specialized my mentorship was more in lung, breast, and GI. Those are kind of the three. But obviously, when you come to the community, you start covering pretty much every malignancy that walks through the door, both hematology and solid tumor. So that's a little bit of myself.
Great. Thank you so much for that introduction. Let's move over to Tammy. I would love to hear a little bit about your background and tell us a little bit about your diagnosis.
I became a patient of Dr. Groteluschen back in 2022 after firing my initial oncologist. My initial oncologist really wasn't giving me told me I was out of options, and I didn't want to believe that. And so I met with Dr. Groteluschen, and the first words out of his mouth were, "I don't take away hope. We'll have some difficult conversations, but we have plenty of options." And so that's when I knew he was the guy for me.
Were you diagnosed de novo metastatic, or did you have an earlier stage diagnosis initially?
Nope, I was diagnosed in 2014, early stage 2B. Went through a mastectomy, radiation, chemotherapy, did the whole thing, did tamoxifen for several years, and then was diagnosed metastatic in the middle of COVID in 2020.
I know breast cancer doesn't always present with symptoms, but can you tell us a little bit about if you had any symptoms, first of all, and then how you found out that you were living with metastatic breast cancer?
So I was a runner, and during COVID, because I couldn't get into the gym anymore, I was running quite a bit and was having knee pain. So I was sent to physical therapy by my primary care physician at that time. And when I didn't make any progression through physical therapy, my therapist sent me to a sports medicine doctor who thought I tore my meniscus. And at that time, he said, "We just need to do this MRI to confirm, and we'll get you back running in no time," and actually discovered that the cancer had eaten through my femur.
Wow. Oh my gosh. It's incredible how you go in for one test thinking it's one thing and come to find out and discover that it was cancer. I really appreciate you sharing your story as we get to know a little bit about you as we head into our conversation today. Dr. Covington, can we turn things over to you if you'd like to introduce yourself?
Yes. So I'm Dr. Covington. I'm really happy to be on this podcast. I'm in Salt Lake City, Utah. I did medical school at the University of Utah, residency at the University of Arizona. I did a fellowship in breast imaging and PET imaging at Mayo Clinic in Arizona. And I'm currently faculty at the University of Utah and an investigator at Huntsman Cancer Institute.
Thank you, Dr. Covington. It's such a pleasure to have you on the panel today. Thanks for being here.
So, Dr. G, let's turn things over to you. So, from a medical perspective, right, you see clients, patients day in and day out. You're mentioning in your community setting, it could be not just breast, but any type of malignancy. But focusing on breast cancer, when you first met Tammy or when you first meet a patient, how do you approach delivering such heavy news to somebody?
I think it's interesting you use the word hope, and I'll be honest, I don't even remember telling Tammy that when she came in the door. So that's so if I'm just completely straightforward and honest about it, I think hope is a very interesting word in the cancer world. That's what I would say. And I'm going to say this from my medical perspective outside looking in from a patient, but I think there's multiple levels of hope when people talk about hope. And I think the first thing when somebody walks through the door from our standpoint, and myself and my group, is I think the first thing is just honesty and transparency about what's happening. I think sometimes as medical professionals, we underestimate the ability of patients to handle the truth, to hear good or bad, to hear it, and also to develop a plan. Most patients that I end up talking to, the most important thing is to know what it is, even if it's bad news, but then also have a plan for what that may be. And that plan could be treatment or not treatment, but at least you're going down a route with somebody where you help support them through this decision making. So I think when people talk about hope, from my stand, like I said, some people, when we can't do treatment, the hope may be that I'm going to make a wedding. When we can't do treatment, in Tammy's situation, we did have multiple options. We were able to look for other tumor markers, other, next generation sequence testing. The hope was that we would find multiple options for treatment to line up for her to extend her survival for quality and quantity of life. So I think when people talk about hope in cancer, I think really what it is from my standpoint is honesty about the diagnosis, honesty about prognosis, honesty about quality and quantity of life, and then developing a plan with that patient and guiding them through it. So that's how I really start addressing it. I can get into more detail as we go, how we do it. The other thing I was going to tell you too, Laura, just so you know, and in my opinion, and I hope Tammy can support this, but I think when you say firing physicians, I do think it's important. I think one of the first jobs of any doctor in any specialty is it's okay to get second opinions. I will tell you, I always worry about doctors that say, don't go get a second opinion. From my standpoint, if I'm treating one of my patients, the more minds, the more brains we have looking at something and coming up with ideas, the better. So I'm not usually, hindsight and the retroscope's always 20/20 and things happen and it's easy to come in and look at stuff. But one of the red flags I have in medicine a little bit is if a provider is unwilling to offer a patient a second opinion or unwilling to reach out to other colleagues to say what's going on. I think that's a little bit of a red flag for patients. And in that situation, I'd say, yeah, you might want to consider a different provider because our goal is to get the best care. It's no matter if I come up with it, somebody else comes with it, and to collaborate and do that. So you're talking about kind of firing. I view it more as if your physician's not supporting you in the pursuit of whatever's out there and relaying that communication, that's a red flag. So.
Absolutely. And I couldn't agree more. I always say the more people that are looking at my case, the better. The more physicians and smart, amazing experts who are looking at my case in my back pocket that I can call upon for information, the better.
So you're meeting a patient for the first time in your clinic. Walk me through what happens.
When somebody comes into our office, I think the first thing we do is we sit down. We understand, number one, what they have. And when I say what they have, we understand what their pathology is. So in breast cancer, that is a very important thing you were mentioning. What is your tumor markers? Or when I say tumor markers, I'll be more exact. What are your ER/PR positivity? What is your HER2 positivity? Either 1+, 2+, 3+. Have you had next generation sequencing and what mutations do you have? So we try to understand exactly what their disease is because a lot of people think breast cancer is just breast cancer, but there's multiple different breast cancers with multiple different pathological characteristics. And also what's very interesting too is, and it goes very underestimated, especially in breast cancer. Some cancers aren't like this, but in breast cancer, somebody can start off with an ER/PR positive disease and later it can change and be very heterogeneous to ER/PR negative, or it can change be positive to negative. So there's certain cancers over the course of time that have a tendency to morph into other same malignancy, but other pathological characteristics that are heterogeneous. So we have to be so that's the first step. And then number two is how far has it spread? What stage and what are the locations? And then how do we incorporate that into treatment planning? So I think when somebody walks through the door for me, those are the first two fundamental questions. And with those two fundamental questions, you can then start to establish prognosis, goals of care, and then treatment plan.
So turning things over to you, Dr. Covington. So, as we're talking about getting all of our medical team and doctors in place, over the last couple of months when I was starting to investigate more around nuclear medicine and who these amazing people are on the radiation side, a couple light bulbs went off in my head. First of all, when I think of radiology, there's the mammogram side of the house for like diagnostics, et cetera. But then there's the radiation side of things in terms of like treatment, type of radiation and different types of scans. And really realizing, I feel like some experts in the nuclear medicine, they're kind of like behind the scenes and I don't really consider them. They're not consulting with me. They're consulting with my team. So I would love to turn things over to you and you just get more insight on the amazing work that you do and then how you interface with the oncologists, the surgeons, and at all do you interface with the patients?
Yes, great questions. Um, I am a breast radiologist and a nuclear radiologist. So I have my role in both areas here, and I can definitely explain some of the differences and how things go on each service. Breast radiologists do often see patients, as I'm sure you know. For example, if a woman comes in with a lump in the breast, we often go and scan in person and tell them personally what we're seeing. If we need to do a biopsy, we're right there. If the biopsy shows cancer, very frequently, either the breast radiologist or someone from our team will call and discuss that with the patient. So we are very patient facing in breast radiology. In nuclear medicine, it is true that very frequently we're in a room tucked in the basement or dark corner of the hospital somewhere reading things like PET scans. However, nuclear medicine does also treat certain cancers as well. We'll probably get a little bit more into this later in the episode. Currently, nuclear medicine is not treating breast cancer, but there's a lot of potential that in the future, even maybe the next 5 years, there will start to be some nuclear medicine based therapies for breast cancer. But currently, nuclear medicine physicians do treat things like thyroid cancer, prostate cancer, neuroendocrine tumors. And for those patients, they definitely know who we are. However, for breast cancer patients, it's entirely understandable right now that a breast cancer patient may not know specifically who their nuclear medicine team is. That may change in the future. It is true that we do work very closely on both services, meaning breast radiology and nuclear medicine, with breast oncologists, breast surgeons. I'm very frequently having conversations with them to go over imaging results. And, especially in difficult cases or cases where findings may not be entirely straightforward, to discuss a plan and what needs to happen to sort things out. So, both services provide vital care for breast cancer patients. There are certain differences, which hopefully I've explained a little bit.
Gosh, so many questions are racing through my head and don't know who to ask first.
Tammy, as someone living with metastatic disease, I understand that you get frequent scans. Can you talk to me a little bit about the cadence and the types of scans that you get?
It's very different. With my initial doctor, there was very few scans done. There wasn't a lot of information gathering. With Dr. Groteluschen, it's the opposite. The first thing we do, is scan. PET scans is our number one that we go to. I've had the occasional CT scan to look at some other things, but the PET is really the main thing that the main test that I have. And depending on my symptoms, depending on what's going on with my numbers, depends on how frequently we do that.
Dr. Groteluschen, would you be able to explain the difference between the CT scan and the PET scan? Hey, my friend, sorry to interrupt the flow of this amazing podcast, but because it's Breast Cancer Awareness Month, I wanted to let you know about our Tell Cancer to Go Take a Hike event. I'm reaching out to you to ask for your support to help us raise these critical funds that we need to continue to provide the emotional wellness classes, support programs, evidence-based education, and this podcast, of course, to support those impacted by breast cancer. Because of amazing donors like yourself, last year we've been able to offer over 400 programs serving 6,000 individuals, 57 webinars focused on medical education and information that attracted over 42,000 views, 133 workshops supporting mental health such as expressive writing, art expression, and meditation, and 142 support groups tailored to those living with early-stage breast cancer, metastatic disease, and inflammatory breast cancer. Help us keep our nonprofit, survivingbreastcancer.org, thriving. Join our October 19th fundraising event, Tell Cancer to Go Take a Hike. You can make a donation, sign up, or create a team. Head on over to survivingbreastcancer.org/take a hike to get started. Your support means the world to us and to the people like you that we serve.
Well, Dr. Covington's probably gonna be able to explain better than me out, but where I'll put it in my sense from medical oncology, and I want to kind of show, like, Tammy, every patient's unique and individual, right? So not every patient I see gets primarily PET imaging as Tammy does, and To be fair to what Tammy was saying, I think what you're looking for too, Laura, we call it diagnostic imaging too, like basically how we diagnose something. But I would kind of say in Tammy's case, she really, her metastatic disease was primarily bone only. And I would be very interested during this as we keep talking. I know Dr. Covington is going to be next, but bone only can be tough for us as oncologists to say, is there progression or not? And especially when you're using tumor markers, because, CT imaging, I really do like CT imaging. I mean, you can do very fine cuts. You can see malignant tumors in very tiny, within millimeter cuts of each other and look for growth. It's difficult sometimes, though, CT imaging with bone, just because you can get sclerosis and changes where you don't know if that's disease progression or not. So when Tammy started this a little bit, because she was bone only, we were trying to characterize how extent of her disease, rapidity, or how indolent or non-indolent her disease was. So we started using the PET scan to better characterize that, because in my opinion, and now this is an oncologist and the radiologist can disagree with me, but bone scans are tough too. Bone scans are tough for me to know what's happening in the bone when you have arthritic change and those things. So for Tammy, we were using PET scans. And then as symptoms arise, as Tammy said, we'll sometimes do CT imaging. So really for me, when you ask me to go back to the question, I think CT imaging is a very good test. It's a very good screening test. Can be done very quickly. Typically, it's very affordable or cheaper than for patients. And we get a very nice look at patients' whole body for disease sites. PET imaging, for me, is very good to maybe sometimes better understand indolent versus non-indolent, so how aggressive things are, better characterize bony features, or if we have questionable things we see on a CT scan, a PET scan will sometimes help us understand, is that malignant, is that benign, how much do we worry about that? And from my standpoint, we kind of use CT and PET together, as Tammy was saying, based upon symptoms and based upon tumor markers, which that's a long conversation too on what you do with tumor markers, but to understand where her disease is at and make decisions on treatment. So hopefully that answers your question, but that's how I view that.
Yeah, absolutely. It's really helpful to hear how you approach this and then decide what scan to order, and sometimes using it in combination. I think as patients, when we're just talking to our breast cancer friends, it's hard not to fall into that trap of, oh, I just had a CT scan. Should I advocate for a PET? Or why did you get this and I didn't get this? And so I think you bring up a really important point that every individual is unique and different. And it really is looking at that conversation with your oncologist to say, what is it that we're trying to solve? What are we trying to find out? And what is the right scan to get that information so we can make informed treatment decisions?
To your point, that's why also when patients, I would be careful to say frequency of imaging can also change based upon patients. So there's lots of things you can look to do that. So a lot of patients always come in and say, well, I read that I do it every 2 months, or I read I do it every 4 months. But when you get in situations based upon symptoms and based upon clinically how patients are doing and those things, frequency can change a lot too. So to your point, that's very individual based also.
Dr. Covington, let me kick things over to you from the radiology perspective and scans. Please feel free to share your insight on CT versus PET, and when you get these orders, how do you approach it?
There are two basic pathways, at least for staging of breast cancer, that is recommended by organizations like the NCCN. And the main division would be on one side CT with a bone scan. From actual practice, I see the performance of the bone scan being a little bit variable, but you can get a CT scan, or the other pathway you can go down is typically an FDG PET scan, now with an option also to consider FES PET, which I know we'll discuss shortly. A CT scan is an anatomic scan, meaning it gives anatomic information. So for cancer detection on a CT scan, we're really looking for anatomic changes, which means we're looking for evidence of a mass in the breast. We're looking for enlarged lymph nodes, masses in organs like the liver or lung. And in the bone, we look for changes like sclerosis, where the density of the bone has increased. Or sometimes you look for lytic change, meaning that it looks like the bone is actually getting kind of eaten away. And there's different anatomic signs we look for. On the other hand, with a PET scan, we're typically looking for some kind of physiologic information. For example, an FDG PET scan allows us to look for areas that have increased uptake or use of glucose, which is basically sugar. So we know that things like cancer really like to have a lot of glucose because it helps it grow, it helps it divide. These cells are very wanting to grow and divide, so they like to have this glucose available. And that's a completely different way of detecting cancer when you're looking for areas of sugar uptake, for example, on a PET scan compared to a CT scan where you're looking for like a mass or a big lymph node or something. Now, the trick is with PET imaging, typically it's either a PET CT or in certain centers, you might have access to a PET MRI. And what that means is you have the best of both worlds. You have the CT information, you have the PET information, and we have specialized software that allows us to fuse them together and evaluate both in one scan.
Dr. Covington, since you're bringing up the glucose factor, can you explain that a little bit more and how that dovetails into what you're looking for with a cancer diagnosis?
Sure. Before a PET scan, there are some limitations where we need the blood sugar levels to be relatively low. So you may have had if someone's had an FDG PET scan, they'll be familiar with the fact that they can't eat. And if you drink a sugary beverage, for example, before you come in for your PET scan, it is going to get rescheduled because we do need blood sugar levels to be low. In terms of advising anyone on diet, that's beyond my lane as a radiologist. I'm generally in favor of the healthiest diet one can follow. I think that's, generally good advice. But it is true that on a FDG PET scan, the ability to evaluate glucose uptake is really the key to FDG. Some cancers certainly have a lot of FDG uptake. Newer studies are showing that certain breast cancers may not have a lot of FDG uptake. For example, cancers like invasive lobular carcinoma, that's often abbreviated ILC, in certain cases, not every case, but in some cases, may have less sugar uptake than more common cancers, such as many types of invasive ductal carcinoma. The terms are changing here. So sometimes invasive ductal carcinoma is starting to be called invasive carcinoma of no special type. So I'll throw out both terms here. Sometimes that's abbreviated NST. The basic premise is that some cancers might be better detected with FDG, and other types of breast cancers may not be as well detected by FDG. And this speaks to the point made earlier that not every breast cancer is identical. There are a lot of differences with breast cancer, and our future goal and present goal is to tailor treatment as well as imaging to be as effective as possible based on the subtype of breast cancer that a woman may have or an individual may present with.
It's a very nuanced discussion. So from my standpoint, when he brought up glucose, really what the PET scan's doing is looking for change, and you said it, Laura, change in metabolic process. And glucose is just an indicator of metabolic process. People kind of get tied to the sugar aspect of it, but it's just an indicator of metabolic process. So when I order a PET scan, one of the things besides change what's happening, I'm also getting it because it's very sensitive, in my opinion, for any reactive metabolic change. So that can be malignancy, as Dr. Covington was stating. That can also be infection. It can be arthritic. It's whatever inflammatory metabolic process is occurring. So to me, one of the main values of a PET scan is a negative PET scan because it's so sensitive. That's actually a better value sometimes. And now I know that positive is good too, but I also like the fact that say negative. So when we say sugar, really the PET scan glucose is far different than what people are saying sugar for my diet and driving malignancy. It's two separate, very nuanced things. So first off, I would say that very nuanced, like the glucose and PET scan is mainly just a metabolic process indicator of inflammation, as Dr. Covington say, driving that. I think sugar in cancer world, so we get to it, is basically, I'm going to say is not true. Now, I'll say this in very subtly because there is some evidence that artificial sweeteners, some of these things that are coming out, can increase risk of malignancy. So when I say not true, I would say more artificial sweeteners, those things are starting to come out, not clear. I think sugar, in my opinion, when I talk to patients, it's more about healthy diet, as both Tammy and Dr. Covington said. And what we know, one of the primary risk factors for malignancy going forward is actually obesity. And most likely the reason obesity is, and now this is me projecting a little bit, maybe, so I want to be careful not to be 100% on this, but obese or fat cells in our body for males make testosterone, for females make estrogen. And if I am obese and I have too much testosterone or too much estrogen in my body, that exposure to those hormones for some people has a tendency to cause malignancy, as we see with ERPR positivity. So I don't think it's as much sugar as much as it is a healthy diet, as Tammy said. I mean, there's some malignancies, as you said, you can have the healthiest people in the world, and it happens. Uh, but I also think that when you talk about sugars, when I talk about, I'm talking about not eating the diet that as I did when I was younger, where it's all frozen foods and artificial, and you want to have a healthy organic diet, you want good foods, you want a balanced meal. And so to me, that's where the sugar content comes in. Not that you can't have the piece of cake, as Tammy's saying, that's great. It's more, how do you have a general healthy diet, healthy weight, healthy activity to do stuff? So it's not depriving your body of the sugar per se, it's being healthy. And if somebody comes to me with sugar, I'm going to say, it's more not having artificial sweeteners, not having those. It's, if people can afford it, organic, those types of things. Fruits and vegetables are going to be great. It's very well known that antioxidants help. What's amazing is when you look at the studies for antioxidants, all those colorful fruits and vegetables have tons of antioxidants. When I was in Madison, we did phase 1 clinical trials. When we actually gave people IV antioxidants, not the natural way, we had worse outcomes sometimes. But when people eat it naturally, they do great. It's better. So there's something that our body needs from that. So to me, sugar, when you talk about it, is all about healthy diet and natural things, and not doing these other artificial things. So it's a very nuanced discussion, and there's lots of rumors that occur out there with people. But I would tell you the PET scan glucose is different than real life. And then the big thing on focus on sugar, in my opinion, would be just how do you change your diet to be healthy, healthy weight, healthy exercise, fruits and vegetables, all those types of things.
I really appreciate that. I think sometimes we hear the word glucose and then we just make the assumption that's sugar, and then we go to the extreme. And so just hearing that differentiation, these nuanced cases, is really helpful. Going back to the scans, and Tammy, did you know the difference between the FDG and FES PET? Or is that something that you learned along the way as you were navigating your diagnosis?
It was something that I had read about that was new and not available everywhere. Some of the bigger centers had it, the Mayos, the MD Anderson type places. So it was just kind of something that was out in my peripheral, I guess, that I'm like, okay, well, maybe this is something we should look into. And so then that's when I brought it up as, hey, we're not really sure what's going on. Is this an option? We just didn't have a place to biopsy that was a good place to biopsy to really get a picture of what was going on. And so it seemed to be a possible option that I brought up.
That's really great to hear. So you kind of did like your own research to see like, this is out there. Am I a candidate for this? And, to what we were talking about earlier, the tumor markers can change, right? You can go from ER positive to triple negative or something like that. So how do we know that we're getting the most effective treatment? So that makes a lot of sense.
And we were at that fork in the road of which treatment option to go to, and as Dr. Groteluschen, sometimes I get in my mind something that I think is a good option that turns out not to necessarily be a good option. And so it was really needing to know, what direction do we go in now?
And so with the FES PET, what were you able to discover?
Well, I'll let the professional answer that question. I know I didn't get the results I wanted. I was hoping to see much more of the ER positive on the scan than what appeared. So it was good because I had in my mind, I want to go back to another CDK4/6. Like, all this research shows you can repeat it, you can go back and let's try that route. So I didn't get that option. But it provided us with some good information.
So Tammy obviously is a unique case, and so primarily bone-only disease. Her pathology, to your point, Laura, her pathology was changing a little bit back and forth. We were getting ERPR positive components. We were getting ERPR negative components. We had to do bone biopsies because that's where her bone is. And I don't know how much you probably are aware of this, or your group is, but sometimes pathology on bone specimens can be very difficult. Just because there's not a lot of tumor there, or because you calcify the bone when they take it out. So you can't always rely on what's there. And clinically, I would say her clinical symptoms, her tumor markers were not matching with what we were seeing with regular PET. or with regular CT scans. So we had all these kind of different variances occurring. Now, we don't do the FES PET here locally yet in Green Bay because we're still a community oncology place, but where we talked before, reaching out to our partners at UW-Madison, who we know there, I reached out to them, and Tammy was nice enough to go down and see them because we were looking for multiple opinions and clinical trial options and things we could do differently. And they actually have an FES PET. So we said, well, wow, why don't we consider this? Because we're just having two different type of breast cancers. Have we morphed from something different? So really what it helped us do is when we did that, we were actually able to identify in Tammy's situation, we probably do have, I'll use the word heterogeneity, but we have a couple different breast cancer pathological lines that are occurring. So then to Tammy's point, we didn't get the answer we wanted because we had uptake with it, but it allows us now better to define what treatment to do and also to define how we want to follow this. And I think the big question, which her and I haven't talked about yet because she's doing well on the therapy now based on her tumor markers and how she's doing, but is what are we going to do for follow-up imaging? Do we need to do repeat FES PET? How do we compare that? I mean, we actually, to be honest, haven't sat down and talked about that quite yet because we changed our therapy and started watching how she's doing. So, but that's really what brought us on to start using that is because of just the atypicalness of it. And it's been very helpful, to be honest. It allows us to better characterize her disease and make very informed treatment decisions.
And Dr. Covington, from your perspective, when you're looking at these scans, what are you trying to decipher? What do you see?
So on an FES PET scan, we're specifically looking for sites of estrogen receptor positive breast cancer, so ER positive breast cancer. And that's different than the FDG PET scan where we're looking for metabolic activity. On an FES PET scan, the pattern of uptake is a little bit different than what we see on FDG. And that's true for other types of PET tracers as well, because we now have many types of PET scans, not just FDG, which typically, 10 years ago, if you said PET scan, you're generally safe to assume that meant FDG. That's no longer the case today. We have even other types of PET scans as well. But for breast cancer, it's typically FES and FDG. For FES, we are looking for estrogen receptor sites. And basically how it works is FES is a form of estradiol, which is basically estrogen that is attached to radioactive fluorine. So you have a little bit of radiation attached to estradiol. You inject it through the veins and let it circulate through the body. And if there are areas in the body that have estrogen receptors that are able to bind estrogen, that estrogen will stick. Because it has radioactive fluorine attached, we can detect it on a PET scan. And on the image, it looks as an area of increased uptake, which is typically going to be in a pattern that is expected for breast cancer. So when I'm reading an FES PET scan, I'm looking for uptake in the breast, obviously. I'm also looking for uptake in lymph nodes in the armpit and chest, lower neck. You're looking for areas of abnormal uptake in the bone, other sites such as lung and brain. Every type of PET scan has certain limitations. And for FES, one of the primary limitations is that estrogen is cleared through the liver. So the liver just lights up like gangbusters on an FES scan. So that makes it a little bit harder to detect things like liver disease. FDG also has certain limitations as well. And that's not unique to FES, but it is important for whoever is interpreting these scans to be very familiar with the expected pattern of uptake, to understand the limitations, and to be able to confidently say whether something is suspicious or not.
Is one way to kind of think about this is, you have an initial scan to see the extent of disease, and using Tammy, your case with bone mets. So you kind of already have a sense of like where in the body this disease is. But then with the FES scan, if it doesn't light up, but you know that there was a tumor there, that's going to tell you information that because it's not lighting up, it's not being receptive to the estradiol, the ER positive piece is not attaching to that. So you're kind of almost using like this jigsaw puzzle of overlaying all of this information to kind of see the extent of disease and the type of characteristics it has. Is that correct?
Yes, extent of disease. And also, like you said, if you have an area of known tumor that does not bind to the FES and you expect it should have bound, that might suggest that that tumor is no longer functionally ER positive, and that has potential therapeutic implications and can be very important information to know about.
So if you have like a bone biopsy too, where you have low ER/PR positivity, so let's say, ER positive can be 99%, ER positive can be 20%. So let's say we have an ER positive 20% and we do an FES PET and it doesn't light up there. That makes me more inclined to say, is this really truly ER/PR positive disease? Not saying the pathologists are wrong on that, but it starts wondering, what do we do with that from a standpoint of treatment, as Dr. Covington was saying, or in Tammy's case too, when it's not acting like you expect it to act. And then you do this FES PET scan and you see that it's a different type of uptake, then that the next step from my standpoint as a medical oncologist is, if that one's different than what we expect, do we need to biopsy that one site? Is that still the same thing that we're seeing? Does this have different markers on it? Do we need to do different, all those therapeutic implications that come to that? So that's really, to your point, Lori, you're right. It's a jigsaw puzzle that you put together in the treatment as you're treating somebody to try to understand, once again, kind of going back to what we talked about. My original thing is, where's your disease at? How rapid is it moving? And what is it? What is the pathological characteristics of it that allows us to treat it the best way?
I continue to be overwhelmed by how complex breast cancer is. I think, as we started off earlier, even before my diagnosis, I thought breast cancer was just the big pink umbrella of breast cancer. It's October, it's the pink ribbons, these walks, etc. And until I was diagnosed, I didn't know all of the subsets and subtypes that can happen. And, Tammy, I don't know if you personally have experience with this, but what we also hear in the community, right, with metastatic disease, we're always going in for scans, but then you can get these results where some parts of the body it is stable or it's shrinking, or in other parts of the body it has grown or progressed, etc. And so this dichotomy of, well, is the treatment working? Is it not working? What is actually going on? Why is it not behaving the way we expected it to behave? Really just adds these dimensions and layers to the complexity of a cancer diagnosis.
Yeah, I used to dissect all of my reports as they came in, as soon as my computer dinged, and I'd have all these things highlighted, and I would come in and Dr. Groteluschen would say, well, that's nothing, or nope, this is, I was convinced that my disease had like blown up all over the place. And he's like, you're stable, you look great. I'm like, well, wait, what about this? And what about this? So it really is having somebody that you depend on to break it down into, what you can understand. And yeah.
Exactly.
First and foremost, I want to say, when we see somebody, we have all this great imaging. Actually, the imaging is great. But first and foremost is always, how is that patient clinically doing? If that patient's tolerating treatment well and clinically doing well, we hope that the scan corresponds and tells us that. Those are the easy patients of like, yep, we keep moving on treatment, or we have to adjust the dose if you're not tolerating treatment. The harder patients, and Dr. Covington can probably, when we have this in the breast cancer world and at our breast tumor boards, is they're clinically doing great. Their tumor markers are going down, and we happen to get an image that shows something getting bigger. What do you do with that something getting bigger? What does it mean? Is it disease progression? Do we need to change? And those are very difficult patient discussions. And most of the time, we lean towards, if they're tolerating treatment, continuing treatment and getting a close follow-up scan to try to identify, is this something we have to do, or is this an isolated metastatic? We call it oligometastatic. To Dr. Covington's point, there's some evidence coming out when people have progression of oligo or individual sites that you can actually treat those locally, and they can continue on their current systemic therapy and do well from a survival standpoint. But those are very tough cases in terms of like when they're doing that. And then the third bucket is clear progression, right? Clinically not doing well, CT. And those are cases that, from a decision-making standpoint, are easy for an oncologist, but from a family standpoint and patient standpoint, are obviously not good. So those are kind of your buckets when you're talking about breast cancer that we live in. And fortunately, in breast cancer, survival has increased so much, and we have so many weapons and so many options, that I think we're seeing more and more of these tough cases as you just described, because 16, 20 years ago, honestly, with metastatic breast cancer, women didn't live as long. And now we're moving breast cancer into this almost chronic disease state where women can live on medicine that they can tolerate for a long period of time. And we're seeing things and dealing with things that we never did when at least when I was training in residency and fellowship. So it's exciting, but it does beg many, many questions, as you brought up, Laura, in terms of how we do stuff, and requires the ability, as we talked about, to talk with everybody, the team, the patient, and develop the best patient plan.
Dr. Covington, were you going to add to that?
I think it's important to recognize that no imaging test is perfect. They're good. We're always getting better. I'm still looking for the perfect imaging test, and I'd be very happy if we find that during my career. There are certain cases where the imaging might not match the clinical presentation, and that can be a conundrum. Sometimes it requires something like a biopsy. In other cases, it simply requires more time, and time will generally tell the difference between something that is truly progressing and something that is a false sign of progression. But that is really where the conversation between a radiologist and the treating team is important. And things like multidisciplinary tumor boards can really be helpful to get a wide variety of opinions to come up with the most informed decision possible. I think all of our goal is to be able to be accurate 100% of the time. But the reality is that imaging is very good, but still not perfect. And in certain cases, we have to put our heads together and figure out what the best next step is.
This is just one of many more conversations I would love to have with you guys.
As we conclude today's conversation, I would love to ask each of you to reflect and share what you are most excited about as it relates to the field of breast cancer oncology. Tammy, can we start with you?
I think I'll just go back to that favorite word of mine of hope, in that with the new, with the research that's done, the one thing Dr. Groteluschen always, with any progression, is let's look at clinical trials. Let's see what's out there. And even with the PET not getting what I had hoped for, it did open doors for future clinical trials that will be a possibility. So I think that's what I'm the most hopeful for and excited about is all the new treatments that are in the works, that are out there, that are coming, treatments that used to treat something else that may now be beneficial for those of us with MBC. So that's what I'm excited for.
Dr. Groteluschen, what are you most excited about?
We're in the process of doing it, but I think it's just going to take off more, but targeted therapy. And when I say targeted therapy, I'll be more specific but both immunotherapy, targeted therapy, but the ability to take somebody's tumor and basically look for next generation sequencing or mutations that allow us to target that in a treatment standpoint, which they do not have toxicity. They can stay on the medication and control their disease and basically extend their survival and live a normal life. We've had when I started, to give you back 20 years ago, we had like 3 medicines for metastatic breast cancer. Now we have just endless amounts of medicines that I can't even do. And we can kick it over to Dr. Covington, but even targeted therapy, as he's probably going to say too, is, nuclear medicine targeted therapy. I mean, FES PET now is a way that you can basically identify multiple metastatic sites through estrogen. What they're doing, then he'll talk about it probably, but you can start doing stuff we do in prostate cancer, which is basically do focused nuclear medicine or radioactive to those areas to kill those areas. So just the standpoint that we're now able to identify, target, and molecularly target these cancers is starting to open up a whole new world of what we can do. So that's super exciting. And then the other thing, I'm just going to plug this. The next big exciting thing, and this is prevention. Our mammograms and stuff become so much better. And we're talking a lot about metastatic breast cancer, but the key to all this is still for women to have prevention. It's still prevention. So the imaging, the mammograms that they're doing are so much more advanced now that we're picking up things earlier. So prevention and then genetic testing. So I'll say targeted therapy, prevention, and genetic testing is really important for us.
Yes, I agree with everything that's been said. We really are experiencing a renaissance in nuclear medicine right now. In addition to FES PET scans, I expect multiple additional types of PET scans will become available for diagnosis. Current options include things like FAP PET, FAPI PET, sometimes it's called, which allows one to image fibroblast activating protein, which is apparently highly expressed in breast cancers and many other types of cancers. This type of PET scan has a lot of potential to have less false positives, less uptake in things like inflammation compared to FDG. There's potential to have PET scans that evaluate HER2 receptors, progesterone receptors, many other types of receptors. I think all of this will allow us to be more accurate with our diagnosis. Paired with that, there's the potential to use some of these exact same targets and attach something like lutetium, for example, to that target and then treat those sites of cancer. That's what is currently being done for certain types of prostate cancer, and we're seeing very good results there. The clinical trials are now running and will increase over the next several years for breast cancer. We've seen great results with prostate cancer, neuroendocrine tumors. I think breast cancer is the next frontier, and I expect to see very good results from those studies. And that will open up additional options for treatment. And that is just what we, about the best we can hope for. Better imaging, better therapy, lots of advances in oncology as well. It's an exciting time.
So thank you all for taking the time out of your busy schedules to share your expertise, to helping me and our community and our listeners understand and take a deep dive in these topics. Tammy, thank you so much for sharing your personal experience. And not just your personal experience, but opening it up to Dr. Groteluschen as well as your oncologist to be here. I think what I call an SBC is survivingbreastcancer.org first, because we've never had a duo like that before on the podcast. So thank you for being our first. Dr. Covington, I appreciate that our mutual friend Leslie was able to connect us through My Density Matters and for you to share your expertise both in radiology and nuclear medicine. This, like I said, I feel like I have many more questions, but I know our hour is up, so I want to be cognizant of everyone's time. But thank you for joining us today.